I want to tell you that this was actually to be a physician-oriented talk. What Ginya just told you, the talk at Scripps Institute, I was told was going to be a primarily physician-based audience. But anyhow, having said that, I think you'll get it. Okay, you don't really have to focus on so many slides. I'll kind of talk the highlights to you. And what we're going to be talking about primarily is lymph node positive prostate cancer. But along the way, I'm going to be touching on a lot of different aspects of prostate treatment, and that's important. And really what we'd like to do is to avoid you having lymph node positive prostate cancer, and I'll try to show you how that could potentially be done. Next. Okay, so first thing that comes to mind is I'm talking about prostate and lymph nodes. Okay? Typically if you have prostate and lymph node, you're told, well, you're incurable. You need hormones, get your affairs in order, the hormones will run out, and you know, that's just the way it is. It's basically a death sentence. But then you say, well, why is it that ladies who have breast cancer and lymph nodes are treated definitively and curatively, and colorectal cancer and head and neck cancer when they have lymph nodes are treated definitively and curatively, and all these other cancers, even lung cancers, are treated definitively and curatively, but prostate is not. And that's just been a historic rule for prostate cancer. Lymph node disease is just bad, too bad to be treated if you have lymph node disease. Next. So there was an RTOG, which is a giant group, the Radiation Therapy Oncology group, which defines standards of care. And they define what lymph nodes would be at high risk for developing cancer, and these are those. And they got it right. Next. And they basically follow along the pattern. See these little dots? Okay, they're following along the vascular pattern of circulation. And this is the aorta and the inferior vena cava, and then it goes down to the common iliac. But anyhow, that's kind of a lay of the land of where prostates kind of live. There's a few that are actually around here in the presacral area and a few in the perirectal, which I've come to appreciate since 1990, having done a lot of lymph node analysis. Next. Interestingly, prostate cancer sits in the center of our bodies, difficult location, and betwixt the bladder and the rectum. But so does cervical cancer. And interestingly, there was a GOG study, and they found that when they treated lymph nodes, okay, not only the pelvis, but up to the abdomen, they ended up with a 50% 5-year survival. That was actually surprising, to the point where the RTOG started a study. And when I talk about these RTOG, and you're going to see SWOG and a lot of other different studies, these are called evidence-based data. Okay, and what that really means is you take two patients, they have similar disease, and you go behind door 1 and get that treatment, and you go behind door 2 and get that treatment, and then we'll see how things are in 5 to 10 years. It can't be denied. Okay, so this is what we follow in medicine, and this is what we also grow from. So we look at these studies, and we often say, well, how can we do better than these evidence-based trials? RTOG did look at cervical cancer, and again, they treated just pelvis versus pelvis and periaortic lymph nodes, and look at the difference in survival. That's a lot. Okay, you're talking about 11% there at 10 years. Okay, if you're one of the 11%, that's not good. Okay, so if you're part of that 55% who survived, that's great. Next. So let's talk about prostate. Who would benefit most from nodal radiation? Next. Well, clearly patients who have had surgery and patients who have T3 disease outside the prostate, high Gleason scores, which are typically 8 to 10, and pathologic N1 disease. That means you've been diagnosed as having lymph nodes and they are positive. Okay, also, this would have been after surgery. Okay, so after surgery, these are the patients who are going to benefit the most. Or if you present with high-risk intact prostate cancer, clinical T3 disease, PSA greater or equal to 20, a Gleason score of 8 to 10. Bad things, okay? Shouldn't be going to surgery in the first place. These guys shouldn't have been going to surgery in the first place. But anyhow, be that as it may, I'll see if we can clean this up. But these are the two groups that are going to benefit the most with respect to lymph node disease, are going to have lymph node disease associated with them. Next. So this is what I was referring to, the evidence-based data, the clinical trials, and which the ones I picked were the most relevant and most talked about and got me to where I am today in terms of treating lymph nodes and can support that. Next. So RTOG 7506, this was the first doctor who kind of thought outside the box, because he led this RTOG group. And he said, you know what, for patients who have N1 disease, meaning lymph node positivity secured, that's not, they see something enlarged, they actually documented it with a needle and got cancer. He said, let's treat the periortics. And lo and behold, at 5 years, 63% were survived, and 29% were surviving, almost 30% at 10 years. That kind of flew in the face of conventional wisdom. Next. There was a study at Sloan Kettering where the similar thing was done, treating lymph nodes, N1 disease, and at 15 years, overall survival was 34% and local control was 75%. Both of these studies far exceeded the expectations, and this kind of led us down to what we'll be talking about in the future of this talk. Next. So let's first talk about salvage versus adjuvant postoperative radiation. And salvage means you've had your surgery and you're now going to wait and watch your PSA. And when it gets to a certain value, you may or may not be sent for radiation or hormones or whatever. Adjuvant means you've had your surgery, you have adverse features, and you're planned. It's planned that in 8 to 12 weeks you're going to get postoperative radiation. There have been 2 studies and surveys, I should say. One showed that only 7% of urologists or oncologists referred patients for radiation or hormones, and another study showed 13%, so it's far underutilized, okay? And we can do much better next. So this is a very interesting trial that I found because it was an NCI study and, again, evidence-based trial. And what I find so interesting about it is that you can see that after surgery, when the PSA reaches 0.2, okay, you have 48%. We could do better with this, I'll show you how. But with every increment up, 0.5 to 1, 1.2 to 1.5, it's already down to 28%, so 20% lower. 1.51, it's down to 18%. This is kind of scary, okay? And the reality of it is the patients who did get radiation in this particular group, and this should say less than 4%, grade 3 toxicity. Shortcoming was that the radiation dose was relatively low. But it's a nice study just because it just kind of, in a very stepwise pattern, shows you how just a small inching up of the PSA really impacts biochemical progression and then overall survival. Next. It actually goes with another study. This is an important study, the SWOG 8794, and this is about adjuvant radiation. And what they did is they got equal matched groups, and they took one group and they said, okay, you guys had bad things found, we're going to treat you. This group said, okay, we'll just wait until your PSA gets to greater than 0.2. And as you can see, at 12.7 years, the median overall survival for the patients who got the adjuvant was 59% versus 48% at 11%. Okay, and so radiation in the adjuvant fashion was really shown to have an impact. Meanwhile, the patients who were treated with radiation and or hormones had no statistical significant incidence of urinary, bowel, rectal, or erections. So the question has to be, why not? Okay, so, and I'll show you some data to further support this. Next. This was an interesting study where they basically said, okay, we're going to wait and see for your PSA to get to greater than 0.2, or we're going to just give you post-op radiation. And look at this at 10 years. And the patients who got the radiation, 61.8% versus the guys who watched and waited at 39.4%. Not very good, very statistically significant. That's what the p-value shows. Next. Then there was the Milan match-based trial, and this is interesting from the standpoint of now we're finally getting into multimodal. What does that mean? That means that we're taking one group and we're giving them radiation, okay, and after surgery, that is, radiation and hormones versus hormones alone. So that's really asking the question, did radiation have any impact? And again, at 5 years, you can see 95% and 86% in the patients who got the radiation with the hormones versus hormones alone, 88% and 70%. So this is a group of patients who would you'd be told, okay, you got lymph nodes positive or you got advanced disease. Incidentally, this trial encompassed both patients after surgery as well as patients who had locally advanced disease at presentation, meaning they still had their prostates intact. But again, there was a statistically significant 16% difference at 10 years. That's very important. That's a cancer-specific survival. Cannot argue with that. Next. There was another study, by the way, that followed that from the Milan study to the Mayo Clinic, and it was a mirror image of it. This is an important study, 8531. These are patients who had prostatectomies and intact prostates. And again, multimodal. Multimodal meaning this group of 977 patients, very equally nicely matched, 408 versus 489. The 488 got adjuvant radiation and then hormones. This group got adjuvant radiation and then, well, I'm sorry, they began hormones and radiation when their PSAs got greater than 1.5. And as you can see, every single parameter, absolute survival, disease-free survival, biochemical survival, and even broke it into Gleason 7 through 10 survivals, benefited in a very statistically significant way, with these higher numbers being the groups who got the triple therapy, okay, meaning hormones, radiation, and maybe surgery. But it's a combined modality event. And this was actually duplicated by ERTC. This is the BOLA study next, which BOLA, well, no, this is not the one. What they tried to do is say, okay, well, if hormones are working, but if you're not a hormone bug, and by the way, I'm not a hormone bug, and I don't like giving hormones because I think they have a lot of downsides, but I'm showing you a lot of upsides from hormones, so we may have to weather that storm. But giving Casodex at 150 milligrams a day for a couple years in a patient who has locally advanced prostate cancer or an elevated PSA after RP, what you see is in arm 1, those are the guys who got 2 years of 150 milligrams Casodex versus the guys who were just getting the starch pill, and 57 versus 40%. Okay, and that's at 7.1 years. It's a 17% differential with respect to biochemical progression. Okay, and that also in this study was a disease progression as well. The patients did have problems with gynecomastia, meaning enlarging of their breasts, and there's a question and a study which will soon be run using a lower dose of Casodex to see if it has the same impact, but it hasn't been done yet. And we have ways of stopping that gynecomastia problem. Next. This got so much press. The 22863 BOLA study is ERRTC, and they looked at primarily intact prostates with high-risk features. I say bad stuff, T3, T4, Gleason 8 through 10s. They randomized the patients to get pelvic radiation alone or pelvic radiation plus 3 years of hormones. I will never do 3 years of hormones, but they did find a statistically significant benefit to the tune of 47% over 39%, 30% versus 10% with cancer-specific survival. This one here is really important. And hormones can exacerbate cardiovascular symptoms, but in this study they looked really closely at cardiovascular disease and they found no significant adverse cardiac events. Again, this was a evidence-based clinical trial specifically looking at these things. Next. Okay, so it appears there is a benefit to radiation. Next. And what about toxicities? Well, in all the studies, there has been no study that has demonstrated that either adjuvant or salvage radiation is associated with greater than 1% radiation morbidity. So they're all less than 1%. So again, the question is, why isn't my urologist or oncologist sending me for the radiation if it's going to cure me? Okay, why is only 7% in one survey and 13% in the other survey? It doesn't make sense. Okay, it's just so obvious. Again, these were major trials. Next. This is an interesting style. At Stanford, what they used is dose escalation. So they asked the question, okay, we have these patients, they have nodal disease. What if we escalated the dose and went from 60 gray and went on upwards to 76 gray, and just that amount of dosage, that's about 2 weeks of radiation, resulted in 25% biochemical freedom at 5 years, over double, okay, with a higher dose level. Okay, that's statistically significant, and there was no higher incidence of adverse effects, meaning no damage to the rectum, bladder, rectum, or erectile dysfunction. So they concluded that higher doses increase the likelihood of being cancer-free. Next. Here's a study which was looking specifically, again, at high-risk intact prostate cancers, meaning T2C to T4 with a PSA less than 150, and these patients received 2 months of hormones during radiation or 2 years after the radiation. And again, that 2 years after the radiation did give an 81% versus 70%, that 11%, okay, in patients having Gleason scores of 8 to 10. All the groups benefited, but these groups, these 8 to 10 Gleason scores really benefited as well. There was the one trial that I've shown you, which is 9610, which did show also Gleason 7 tumors benefiting from hormones. Okay, again, I'm not a hormone bug, but you start looking at all this data, it becomes a mountain that you gotta look at and say, I gotta at least offer it to the patient. Next. So salvage versus adjuvant, well, it appears that the studies suggest that adjuvant's doing better than salvage, and that salvage patients actually do have approximately 10 times the disease burden when treated compared to the patient who's treated adjuvantly, meaning your plan to have radiation. It's on the books. You had your surgery, we found some bad stuff, you're getting radiation. And currently there's a double randomized trial comparing salvage versus adjuvant to really answer this question. Next. And the take-home message is just don't wait too long. If you have prostate cancer, don't leave it up to your urologist or oncologist, because I already told you that what the survey shows, because they may not be paying attention to the fact that once that PSA gets above 2, you're very unlikely to benefit from radiation, hormones, or anything. Okay, so you really want to get it before this number. And that number was first brought up about 20 years ago from Dr. Schild at the Mayo Clinic in Rochester, Minnesota, and has since been whittled down, as I showed you in the beginning. And next, to the point where it's somewhere between 0.2 and 0.6. This is the Radical study, and it's basically saying you have surgery and you go on to have adjuvant radiation, and then they mix it up. 6 months of hormones, I like that, versus 2 years of hormones, or without any hormones at all, and radical prostatectomy and salvage radiation. That's when your PSA is greater than 0.1, 6 months of hormones, 2 years, and then of course without any hormones at all. And they're still accruing patients. It's an ongoing study, but the preliminary data is already suggesting a benefit to adjuvant radiation. But we will still wait for the end trial, because this is not the final analysis, just preliminary data. Next. So postoperative salvage versus adjuvant radiation. Well, it appears that the earlier you get your PSA following surgery, post-op, the better you're going to do. Okay, now whether it's salvage or adjuvant, I'm not sure. These studies are going to answer the question, but surely if it's salvage, don't let your PSA get too high. Try to get it as low as possible. If it's adjuvant, well, that's great. You're in the most contemporary data showing the best results. Again, the R2GO 534 and the radicals are seeking to answer that question. Other things that need to increase in the radiation dose, and there's a lack of radiation morbidities, which have been quite impressive. There is a question, can hormones be lessened if the radiation dose is increased? And that's being looked at as well. Next. And that's basically what this trial is showing. We don't have to spend a lot of time here. It's basically what I just said. Can you diminish the time frame or length, duration of hormones, which do have side effects, if you escalate the doses of radiation? I think the answer is going to be yes, yes, yes. Next. The prostate-specific antigen working group says, you know what? Don't wait for your PSA to get greater than or equal to 0.4. Okay, and this is a group out of Washington. Again, it's a consensus panel, and that's their recommendation. So you should share that with your urologist or oncologist if you're a patient who's had surgery and you're watching your PSA going up and they're not doing anything about it, and say, well, wait a little longer. That little longer means survival. That's really important, and I can't emphasize that enough. And a lot of people also get thrown in after surgery into the basin, or even after radiation, of having a fairly low PSA, because after all, that's not a sky-high PSA, but the reality of it is it's very meaningful from the standpoint of survival. But a lot of doctors will now say, well, now we'll put you in the active surveillance group. I have no problem with active surveillance, but it doesn't apply to patients who've already been treated. Okay, that applies to patients who present with very low volume, low-risk disease. Okay, those are the only patients who should be on active surveillance. And active surveillance means something. It doesn't mean just get your PSA checked every year or two. It means getting biopsies once a year. It means getting your PSAs at least biannually, if not quarterly. You have to be active. Sometimes all the rigors of doing that and biopsies every year can can mount, okay, and become a problem. But anyhow, this is what the prostate-specific antigen working group recommends. Don't let it get above that number. It's a low number, and certainly don't get into a group of patients where you're just. I'm big on complementary supplements. I love them, homeopathics and such. But again, I'm not going to do that to a patient who I could potentially cure. That's different. Next. So does radiation dose matter? The Stanford group showed yes. Next. And at Sloan Kettering, they definitely showed a tremendous difference. Just looking at this group here, with 64 to 70, they moved up to 75.6, gained about 20 percentile, okay, in terms of disease-free survival. And when they went to 81 gray, it stepped all the way up. This was intermediate and high-risk disease. And as it says, yes, dose really matters. I mean, if you look at this and this, that's like a 45% difference. And again, 2 weeks of radiation. Okay, so it makes the case for elevating doses of radiation. And again, you need to be aware of this. And how are you going to know? You go to a radiation doctor, and he's giving you a certain dose. In this day and age, doctors maybe don't want to give such a high dose because we have these legalities, and malpractice and so on and so forth. But the evidence-based trials have actually shown that with the higher doses there is no increased risks. And so I'll always be treating my patients at the highest dose level that tissues can tolerate. Next. And again, this was Deborah Kuban, a friend of mine from MD Anderson. She looked at this in terms of just 78 grays, just 800 CGY. And there's 73% difference versus 50% difference at 10 years, okay, in terms of biochemical free survival. Big difference. I mean, and this, she looked specifically at evidence-based studies. So she looked at all the randomized trials, and it showed that, okay, and it's a 20% difference. Very, very important. Next. And this is another study which is taking it to another level. I love this study, 0924, because now what they're doing is they're saying, well, what if you just get radiation alone and hormones, or radiation, hormones, and seeding, okay, brachytherapy, okay, you're really escalating the doses, okay, and they still have to accrue. It's an early trial, and there's 250. Their target is 2,500, and they've got 520. But I can bet that the brachytherapy group is going to far exceed our expectations, just because I do it, I live it, I breathe it. Next. Interestingly, there's studies looking at the fact of, okay, you have prostate cancer, we're just going to do seeds alone, that's all you need. Okay, I did a lot of seeds alone. I don't think anyone would debate that I've done more seeds than any person in the world, okay, at this point in time. However, the evidence-based studies has demonstrated that there's actually less morbidity when you combine radiation and seeds to seeds alone. Okay. Meanwhile, looking at survival data, the survival is actually increased also when combining radiation and seeds, making that case. Next. And this is just outlining it in these multi-center trials where you get monotherapy. That means iodine alone versus palladium alone versus combining the external beam radiation with iodine or palladium. Next. And interestingly, the monotherapy group, meaning iodine or palladium alone, seeds alone group, had the most side effects with respect to urinary and bladder and even rectal. And at no point did at this point, this is crude, three-dimensional conformal radiation affect the AUA scores or increase rectal morbidity. So next, meanwhile, the other study on the other side at the University of Chicago demonstrated that the brachytherapy alone group, seeds alone, 59% survival at 5 years versus 80% when combined with radiation. Next. What about locally advanced high-risk prostate cancer? Is it curable? Next. Okay, this graph right here would be you in the perfect setting. Okay, perfect treatment, perfect patient, perfect world. Here you are, okay, and this is percent cancer-free. You desperately want to be at that 100% mark and be treated, and in the best of worlds, you want that line to just go across, straight across, okay? You don't want it going down, okay, because this is time. So over time, you want to remain cancer-free. Next. Well, this is the way it looks with Gleason 8 through 10 tumors, high-risk disease, and as you can see, this is a graph here showing combining radiation and seeds. And fortunately on the top of the pile here, but I like to have company because it substantiates what I do. Atlanta is kind of low, but they're using iodine 125, which tends not to work so well with Gleason 8 through 10 tumors, and that could explain that. But look at all these data here just flying down. That's the surgical data. Okay, so that's surgical data with patients having Gleason 8 through 10 tumors. There should be no patient getting surgery who has a Gleason 8 through 10 tumor. I mean, there's enough data out there, but they'll still push it. And that bothers me greatly because those are the patients I more commonly see afterwards when their PSAs are rising and maybe rising above those numbers that I told you earlier. Next. And when a PSA of greater than 20, again, you know, we're doing really well here. And this is the surgical groups not doing so well, and Indiana just kind of fell right down.
University of Indiana?
Yes, sir. Next. This is interesting because this is a meta-analysis of almost 15,000 patients treated with everything, okay? Just threw everything in a pile and did a statistical analysis with either surgery, radiation alone, radiation and seeds and hormones, hormones alone, high dose rate radiation, cryosurgery, which is freezing of the prostate, robotic surgery, brachytherapy alone. And what they come to find was that these groups here, which is the combined, actually I'm number 41, had the highest rate of being cancer-free, okay? And we're out to, at this point, that's 16 years. We have 20-year data now. It's just unchanged, and you know, I've been reluctant to publish it just because if you're cured at 16 years with high-risk disease, you're cured. But anyhow, this makes the real strong case for radiation and seeding, and the radiation and seeding is almost as good, if not as good, as with hormones. So that's what I was talking about. If you escalate the doses, might you not need as much hormones? Right now, I'd have to say, I'd rather give you hormones because that's what the evidence-based data is showing. But with more trials, we'll make that decision a little better. Next. So, is high-risk prostate cancer curable? Absolutely. And this is data. This is, again, my data. This is data from Virginia and data from Seattle. And the one group that didn't do well was at the Brigham in Boston. And guess what? That happens to be the most cited article in the journals of urology. Okay, and so when they talk about brachytherapy, for what, you know, this is where they head, right to this study right here. Pick an esteemed institution. By the way, that should be with radiation. I'm not sure why it's not. Anyhow, it was a combination. But they used an MRI to guide the seed implants, and it just doesn't work. And you can't get to the outskirts, and prostate cancer begins in the outer portion of the gland we call the peripheral zone, and there's virtually no capsule associated with it. So, but interestingly, this is the data which is most cited. And you know, every time I go through a urology, you know, the Journal of Urology or Urology, we call it the Gold Journal, it's always going to talk right away about why brachytherapy is not so good. They don't talk about our data or Greg Merrick's data or John Blasco's data. Well, that's the way it is, but next. This is a long-term study that I published next, and we're getting there, you know. Here's that line. It smooths out. You're always going to have this fall off. Why? You got high-risk disease. And so high-risk disease, you know, many times the cat left the bag, the horse left, you know, the barn. In other words, if it's gone distantly, well, we're not going to have an impact on those patients, and that's why you have this fall off. But this is pretty good. Next, showing that at a period of 16 years, we have an overall 82% actuarial freedom from biochemical relapse, meaning your PSA is nadir to 0, okay? And with intermediate, it's approaching 90%, with high risk, 74%. And this is a really good study. You know, the other studies I told you were evidence-based, which were a clinical trial. You know, you walk in here, you walk in there, and you get this treatment, you get that treatment. But what we did to really make this data important was we took all of our data and we just threw it at the University of Washington in Seattle and let them go through it. Let them look at our PSAs, let them look at our pathology, let them look at everything, and then churn out the data. And that just adds a tier of credibility to your data. And that's very important. And we had demonstrated an 86% cancer-specific survival at 16 years. Is extremely impressive. And every patient who had a rising PSA, I biopsied the region of the prostate with saturation biopsies, which typically means around 50 cores. Not a single patient had cancer in the prostate region. So I did my job, okay, and that's just what I was telling you. The cancer was farther advanced than that I expected. I treated them for. And it may have gone to bone elsewhere, it wasn't showing itself, or maybe some higher lymph nodes, and that's what I'll show you about. And that's what really this talk is mostly about. Next. interestingly, this PAP, prostatic acid phosphatase, I'm sorry, this is a very important marker. It actually predates the PSA. And in the era of PAP, if you had an elevated PAP, there were surgeons who would tell you, I'm sorry, you can't have surgery if you have an elevated PAP because I'm performing malpractice. The data shows that every patient fails, okay? I never stopped looking at this PAP, even once the PSA did come about, and that was in the mid-'80s, and I was in New York. And I continued to track patients with PSA and with PAP next. And there's been a lot of data, which I've published about 4 or 5, but so has Duke and University of California, San Francisco, and University of Washington, Seattle, and Walter Reed Hospital by Judd Moule. All the data supports the same thing. PAP is as important as it ever was, and that's the data. And yet, if you check, I mean, if you're a prostate cancer survivor or being diagnosed having prostate cancer, did they do a PAP? Because if they didn't, they should. And it's a very important prognosticator, and it may mean you have to be treated more aggressively, and that's what I've done through the years as I identified this to be such an important prognosticator above and beyond the PSA. Next. Okay, so comparing prostatectomy and radiation regimens with and without hormones, it appears that radiation plus brachytherapy, with or without hormones, appears to be superior to radical prostatectomy. Okay, that's clear from the evidence-based data. Okay, next. Can we do better with patients having intact prostates and high-risk disease? Yes, we can. Next, with higher imaging. Okay, so my patients, I showed you that the high-risk group, bad disease, 74%. By the way, if their PSAs, I'm sorry, if their PAPs were normal, that 74% goes up into the mid-80s. And that 89% goes to 94% for intermediate disease if the PAP was negative. Okay? So again, we found that in our own data that the PAP was very, very, very relevant. But using advanced imaging, I may have missed out. Okay, next. So what are we talking about? Well, let's talk about some supportive data. Hellman, Samuel Hellman at Harvard, he identified that patients who had disease from everywhere, he did a multi-organ study, and identified that if disease had spread, whether it spread to the liver, or it spread to the lung, if you removed it, okay, if you removed, we call that cytoreduction, removing the cancer burden, it had a statistically significant impact on disease-free survival, okay? Meanwhile, Singh et al. At Roswell Park, they looked specifically at prostate cancer and bone metastatic disease, identified that if you had 5 or less bone lesions, you can not only be treated, you could be cured. And that just got everyone in a tizzy. You know, how could that be? And when I say cured, it wasn't with the patient with 5 lesions, although it did temper the cancer. It controlled the cancer better. But the patients having 1 to 2 lesions, they could utter the word cure, which was, before that study, was completely, you know, impossible. That just didn't happen. And there's some ongoing clinical trials, and I'm working on one clinical trial myself with what we call oligometastatic disease. Next. So, who would benefit most from advanced technologies? And I'll tell you what this advanced technology is about in a minute. Well, certainly patients having what I just showed you, intact prostates, but also patients after surgery who are found to have high-risk features. In other words, it was a Gleason 8 through 10. You went in having Gleason 6. You come out, they told you, well, sorry, you know, Gleason 10, you had lymph node involvement, seminal vesicle involvement, all these bad things. And also patients who have had radiation alone and fail, brachytherapy or brachytherapy and radiation and fail, they can benefit because their disease may not be so far gone, and the patients may have a chance, a second chance for cure. Next. So after surgery, most doctors will just, this is old data, by the way, just using a box, but it's just showing, this is calling the prostate bed, just treating the prostate bed where the prostate was. Still will have an impact, but using nanoparticle technology, which I'm going to show you, here's the little dots. Those are lymph nodes, and I showed you that earlier where lymph nodes live along the vessels. So if you increase the box, so to speak, you're going to catch more of these lymph nodes. And with a PSA of just 0.5, okay, after surgery, 23% of the men had lymph node positive disease. So almost 25% of the patients with just 0.5. And this is where I get back down to, you know, the prostate cancer group talking about 0.4, and that number I think is greater than 0.2, and the studies will ultimately wash that out. But right now, we're identifying with advanced technologies that maybe this box should be larger, and maybe we shouldn't be using a box, okay? And I'll show you how we do it next. So looking at local disease burden, we like using three-dimensional colorful Doppler ultrasound. I've been doing that for like 25 years, and we do have the state-of-the-art technology. This is investigational, so I won't talk about it. But multi-parametric MRI is combining a whole group of things: endorectal probes, using dynamic contrast enhancement, diffusion weighting, spectroscopy, which interestingly looks at the levels of creatine to citrate, and determines what the volume of cancer is next. And what about distant disease or regional disease? Well, Combidex is a nanoparticle. A nanoparticle is a millionth of a millimeter. Okay, just think about that. Okay, it's injected into your system. Unfortunately, it's only available in the Netherlands. USPIO, also called Feraheme or Feraheme, is available here in the United States at one institution, and that's in Orlando. The F18 FDG fluoride PET CT is really nice for picking up bony lesions that others may not. And then there's the C11 choline PET and the C11 acetate PET. They're good studies. The problem being is they do have a lower predictive accuracy, meaning if you are found to have a disease by one of these studies, it really mandates biopsying the area to make sure that you really do have that disease, because the false positives are a little too steep, or a little too high. Next. From the New England Journal of Medicine in 2003, this was next. This talked about patients with the Combidex, which is a nanoparticle study, and they identified 33 lymph nodes, biopsied 33, all 33 are positive, having lymph node disease. Meaning, if you had disease next, you didn't really have to have your lymph nodes sampled, because the predictive accuracy was just so high. We're in the high 90 percentile. So you just proceed to local regional therapy without performing those morbid pelvic lymph node dissections or abdominal lymph node dissections. Don't be talked into that either, because we do have analyses which can tell us an awful lot about that with a higher degree of accuracy. When you go in with a surgical scalpel, you may be missing the area where the cancer even is, because there's so many lymph nodes. I showed you something that was illustrative of where the locations of the cancers are. There's just a few. But in reality, there's a lot of lymph nodes, thousands of lymph nodes in your body. So this is this kind of study, nanoparticle studies, I believe is the future of medicine. Next. And this is a study just showing the red. And this patient is just loaded with the disease. Okay? And look how it's skipped. I mean, this is where the patient's prostate is. It skipped this area and went up here. Okay? Treated this patient. He's doing well, okay, and he's doing well. And this patient had 46 lymph nodes, okay, positive, okay. What often happens is you never know how high to go or how low to go, because clearly if this is involved, then right here, probably some microscopy, so you gotta go up a little higher. So you have to have a lot of experience with doing this, and you have to have really refined equipment to be able to do this.
That's an image from Combidex?
That is an image from Combidex, yes, sir. Next. F18 FDG fluoride PET. This is a patient on a negative bone scan, but went on to have an F18 study, and this lit up, okay, and bone scan negative, but we did a biopsy of that solitary lesion, and it was positive for cancer, showing you the high sensitivity and specificity, actually, of the F18 fluoride PET CT. So we do like that study, and they do it. It's available here in Sarasota. I've already mentioned the multi-parametric MRI, and I made sure that Sarasota Memorial Hospital has that available, and they do, and they use a dynamic contrast enhanced MRI along with endorectal coil and a diffusion weighting and a high Tesla MRI. Just give me a second, please. Next. Okay, so 3D conformal, 3D colorful Doppler ultrasound, I love it. Next. It's showing me cancer right here. I mean, it's a shame I even have to go to biopsy because it's going to be positive, okay? And meanwhile, with the standard grayscale, it's just hues of gray. It's black and white. It's there's no color. This is telling me exactly where things are going on, and maybe right there. Next, this patient thought he was out of the woods. His PSA was less than 0.1, okay? He came to see me, and I picked this up, and a biopsy. He had a Gleason 8-9 tumor, okay? When the PSA if you're a patient undergoing watchful waiting or active surveillance, I should say, I see a lot of patients, and I have them on complementary supplements like vitamin D3 and resveratrol and pomegranate and a host of complementary supplements. However, my objective is to slow down the progression of the PSA. I don't want to start seeing the PSA going south, okay, because then it's telling me that the cancer is mutated to something that doesn't even resemble prostate, so it has no obligation to make PSA. You'd have a hard time distinguishing under a microscope between a lung cancer and a prostate cancer. So this is an important issue for those of you out there doing active surveillance. The purpose of active surveillance is watching your PSA, but when it starts going down, that's a time where you should actually get a little alerted that something else may be happening. The cancer is mutating and becoming something more aggressive. Next. What else is new? DART. Okay, next. Okay, next. All right, just put it in your face, huh? Bottom line being is we published the first article right here in Sarasota on DART next, and this is all about the fourth dimension, okay? We need to be able to track the internal aspects of your body, every part of your body, because if we're going to be treating lymph nodes up the pelvis into the abdomen where your kidneys and liver and all kinds of critical things and small bowel live, we better be tracking the fourth dimension next. And to emphasize the motion, okay, because you are moving. Even though at our center we have you lie in a cradle and you can't move, but your body's moving. You're breathing. When you breathe, just put your finger between your belly button and your groin. Inhale and exhale. You'll find you breathe more than a cubic millimeter. You breathe centimeters, okay, and we have to track that. Next. Okay, so what's new? What do we have? Okay, we have an exact table. It tells you. It has motion sensors built in it. We have the third generation Sonarray deep frequency ultrasound system with infrared guided tracking lasers sending infrared guided lasers to predetermined points of your body. And it's not if you move, it's when you move, by the way. We have portal vision, which is really neat, using megavoltage technology to track you in 4 dimensions. We have this is really portal vision using amorphous-silicone electrodes in real time. We have the third generation cone beam tomography, which is a light speed or even bright speed helical scanner in real time, giving us actual information about what you're doing right now while you're being treated, so we can actually juxtapose and change things and adjust. And we have onboard imaging and third and fourth dimensional bone-to-bone matching, and really important respiratory gating. So we know that when you breathe naturally, you move. If you breathe shallow or deep, you can move even more. If you hiccup, sneeze, laugh, cough, obviously you're going to move even more. These are all important, very important analysis tools for what we do. Next. So what we're really looking at is biologically directed radiation, because the colorful Doppler ultrasound is telling me where the cancer is within the prostate. The multi-parametric MRIs, which I talked about, is going to also tell us that information, and we have fusion technologies. Everything we do is fused. And what fusion means is you get a study over there, and it comes right to us, and we can put it into our portal, and using a DICOM format can meld the two, so there's no guesswork. And of course, the nanoparticle technologies, and I already talked about the C11 choline and the carbon 11 and the F18 sodium fluoride PET CTs. Next. So that enables us to do some interesting things. Next. It tells us where the urethra is so that we can lessen the dose of the urethra. That's where a lot of morbidity comes from when you're treated with an intact prostate, and also with after prostatectomy. In this particular patient, he has an intact prostate, and it's telling him exactly where the location of the tumor is. That area is going to have a much higher dose. Next. In fact, this is another pictorial just showing you, the red is getting a really high dose. That's exactly where the cancer is, and that's going to make a difference because we already showed you dose matters. Okay, and so if dose matters, well, then this is important. And DART directed directly to this area, or seeding directly to this area, or both, which is what we do, makes a lot of difference. And lymph nodes, if we know they're real, and we know they're real if they're positive by a nanoparticle test, we can deliver a higher dose to them. That makes a big difference. Next. So your Feraheme, you went to Orlando, it's positive, what can I do? Next. And again, we talk about USPIO, and I speak to patients, and they're coming out asking my staff, I don't know who he's talking about this, PISOUT. Bottom line is ultra small superparamagnetic ferrous oxide nanoparticle test. Okay, Feramoxetol Also could have, not much easier, right? Anyhow, using that next, this is good for us, okay? Because now we're fusing, and we directly fuse. We reach into the portal of Orlando and fuse it with our technologies next, and it shows us exactly where the lymph nodes are. And if you could just look at this lymph node number 9, that's a 1 millimeter tumor, okay, that was picked up by this Feraheme. And we're very excited about this, and we're going along the lines, marching forward with data in hopes to get FDA approval for this, so that right now there is approximately $1,500 out of pocket to take that away. But anyhow, this is as good as it gets, the Feraheme, and I'm very, very excited about it. Next. Again, this is showing me a lymph node now outside of the pelvis. Next. And there it is. Okay, and this is astride the aorta. Okay, and this is a periaortic lymph node. Actually, there's two side by side. And again, in my high-risk patients that I talked about, would I have treated this high? Probably not. This may have been the border, you know, and that's what I'm finding as patients fail, and I go back and do a nanoparticle test, and lo and behold, you know, they got these lymph nodes higher up in the pelvis. And I am using hormones in these patients. Again, I just cannot, I'm not a hormone bug, but there's so much data showing that hormones and radiation, 1 + 1 doesn't equal 2, it equals 3 or 4 or 5. It's a super additive event, and until someone tells me otherwise, and you know, other studies mature. I showed you the Radical study, and they did have an arm where they're using no hormones, but that's the arm that's already kind of falling down. And so I do feel that I'm obliged to inform you and really want you to have hormones. And we have ways of mitigating the side effects that hormones can give you. Next. So a patient has disease in the abdomen, and you know, what can we do? We can treat with DART, and we can be so precise that it's just this area, that blue, that's getting treated. Okay, and this would be a patient being treated to the pelvis. And it's just the areas of, it's very precise, it's very refined. I need more pictures of this, but we'll work on that sometime, Ginya. Next. What about CyberKnife? Okay, we're hearing a lot about CyberKnife. Let me just explain some things. There's fractionated radiation, meaning Monday through Friday, once a day. And then there's hypofractionated radiation. That was always a dirty word to us, okay? Hypofractionated radiation. We knew patients treated in Europe and elsewhere got hypofractionated radiation. Why? They're socialized. They only have so much money in the bin for health care. They want to get you in and out, okay? By the same token, if you're a patient, you want to be treated, you know, you got cancer, and so you just expect and accept that, you know, I'm going to have side effects associated with this. Suddenly, here in the U.S., this CyberKnife crops up, and talk about side effect profiles. Well, we're not seeing them yet because we're just starting. But you could bet that as time goes on, these patients are going to have damage to the rectum and the bladder because it is very unforgiving to normal tissues. I write here, and I don't want to get too involved, but there's a lower alpha-beta ratio for late responding tissues. What does that mean? It means the therapeutic ratio, the higher it is, like an 8-to-1, a 10-to-1, a 12-to-1, is better, because what it means is it's killing the cancer 10-to-1 better, 12-to-1 better, even 5-to-1 better. What about when you're using an extreme version of hypofractionated like CyberKnife? Well, now you're not getting that advantage. Now what you're basically doing is you're getting like a 1-to-1 or maybe a 1-to-5. And so the normal tissues are actually getting hit harder than the cancerous tissues. The cancerous tissues will go away because they're giving a high enough dose, but over time, problems are going to ensue. And they don't use four-dimensional technologies, which I was showing you. Next. What about protons? That's another thing. Can protons treat lymph nodes? No, they cannot. But let's just talk about protons in general. Next. Here's a beautiful model of protons. When you go to your doctor, they often tell you with protons, you know, the dose goes in, it doesn't touch anything, it hits your prostate and gives all the dose there and leaves, and nothing, no doses delivered on the out, you know, from the exit, no doses delivered from the entrance. Well, yeah, that is true if you have a tiny tumor of the brain. I worked on the Harvard cyclotron almost 3 decades ago, and what it does is a proton comes in, and then its Bragg peak releases all the dose, and that's for an 8-millimeter tumor. Okay, but what happens when you expand to a 4-centimeter tumor, 5 or 6 centimeter tumor. What happens to the prostate? Next. Well, what you have to do is you have to put filters in front of the beam. So the beam comes in, hits a filter, and exploits the Bragg peak immediately. Next, to the point where you actually are getting this huge dose coming in. Okay, so a very high dose is in the entrance, to the point where you get skin burns and damage to your hips, and you get vascular necrosis. Next. And this was looked at because proton therapy has become popularized. It's very expensive, and so people sometimes gravitate to that, and so do doctors because they're getting reimbursed a lot of money for it. But some large SEER Medicare data showed, and it was published in the Hematology Oncology in 2012, that protons are inferior to IMRT photons. Okay, to me, IMRT was something we were doing like 20 years ago. Okay, but the reality of it is this was a good study. Next, as was a study that was published in JAMA, and it says IMRT compared with proton therapy was associated with less gastrointestinal morbidity. That's the photons, IMRT. Fewer hip fractures and reduced erectile dysfunction. So they were making the case that, hey, you really don't need this proton therapy. If anything, it has disadvantages. Next. So can DART be an alternative to proton therapy? And I'd have to say absolutely yes, because there's so many things we can do, and I've already talked about them in terms of tracking the fourth dimension, tracking you in real time, sonar array, portal vision, onboard imaging, exact couches, exact cables, respiratory gating, cone beam tomography. It goes on and on and on. The list goes on, and you just can't do that. And if you do have lymph node disease, they wouldn't want to touch you anyway with protons. But even having an attacked prostate, I'm just not in favor of it for rational reasons. Next, and others have identified that. So bottom line is, with DART, we can deliver a higher dose, shorter time frame, great precision, okay, tremendous precision. And so I think it is definitely an alternative to proton beam therapy, and if you combine it with seeds, then yes, for sure. And if it's after surgery, yes, for sure. Next. So we feel that the evolution that we've gone through, and it's been a long evolution, like 20 years of going down and marching down the line of motion detectors and things like that to get to where we are, especially for advanced disease. So the evolution is now the revolution. Next. Okay, there we go. And okay, that's fun. And for advanced disease, new does not always mean better. So that's next. There's something Ginia perhaps can give you. It's called the facts, and it kind of highlights some of the pros and the cons of all types of therapies. Let me just talk a few minutes. So I've shown you all this evidence-based data, clinical trials, and where are we going? Okay, well, where we're going is, as I told you, I was going to update my data to 20 years. Would it matter? No. What I'm looking at now is, with these higher technologies, advanced imaging, be it F-18, be it nanoparticle technologies with Feraheme, which is primarily what we're using now, can we do better? Okay, I showed you 74%, so 3/4 of the patients with high-risk disease are cured. That was the highest ever reported. Okay, however, is there a group of that 25% who I missed it because there was disease just outside the prostate? I'm sorry, outside of the top of my field. Okay, was it in another lymph node just above that area? And that's what we're looking at. The data is young, and right now what I generally say is patients having advanced disease and are treated under the oligometastatic protocol, whether it's with a bone lesion or several bone lesions, I don't go over 5, or if it's with lymph nodes, and sometimes lymph nodes and bones, what we're finding is that we're taking and taming a tiger and making a pussycat out of it. That's one objective, and we can control that disease better, okay, more easily. And that's important. People fail to, they want to say, am I cured? Am I going to be cured? You may be, okay, but if we can control it, we don't cure diabetes, and we have a difficult time controlling hypertension and, a whole host of other diseases, cholesterol. We manage them and we control them. So if we can control your disease forevermore, we're doing a damn good job. And I think that's a really important thing. The other side of it, there's a group of patients who we're curing. They're coming back. This is the data I'm working on now, okay? The peer reviewers want to see patients who have been treated, and if they're on hormones, which I do have them on, who are on this protocol, then off of hormones for 3 years. So the data is still young, and I'm just getting to that group of patients now because we really started with the Feraheme in 2010. And so, you know, the patients are now, we're starting to see it. And that will be a very novel database to show to the world. And it all makes sense. And that's where I went with this study. What I did is I showed you the evidence right from treating the cervix to the periaortic lymph nodes to right from, as I said, Dr. Hanks, you know, Fox Chase opening up an RTOG study and just treating the periortics, and Dr. Lee at Sloan Kettering just treating lymph nodes above and finding that these patients were actually cured at 10 to 15 years. They didn't expect that at all because they're all told, you have lymph node disease, you're a dead man. And then we found it wasn't true. So we're now doing this in a very methodical way, collecting our data, and we'll eventually publish it. But for now, I am seeing a difference. There's a distinct difference, and we are, as I say, publishing the data as it comes out. And we have 3 papers out now, and you know, we'll have more. And I think that's the last slide. Okay.